Hello, my name is Larry Edwards. I'm professor of medicine at the University of Florida in Gainesville, and I'm here today to bring you the highlights of posters that were presented at the most recent ACR meeting in Chicago about the crystalline arthropathies. There were over 90 presentations related to gout, as well as the first public airing of the ACR guidelines on the management and treatment of gouts. I've taken 12 of the more than 90 posters that were presented to share with you today. These will fall under different topics, including diagnostic tools for gout and hyperuricemia and the comorbid conditions associated with that, particularly heart disease and renal disease. Also new data on previously FDA-approved drugs. And then, as I do each year with these, talk a little bit about the drugs that are in the pipeline that are coming down the road for treating hyperuricemia and gout and pain. The first abstract I'm going to talk to you about today comes from South Korea. It was an interesting study looking at the very troublesome problem of distinguishing gout from septic arthritis. This group looked at serum procalcitonin as a potential serologic marker for distinguishing these two very similar conditions. As you all know, gout and septic arthritis can present with a very high fever, rigors, chills, high levels of all the acute phase reactants, and look fairly similar. These investigators looked at 41 acute gout patients and compared them to 75 age-matched patients with active bacterial infections. And when they measured serum procalcitonin levels, which has been a marker for infectious processes in the literature for many years, you can see on this table that there is quite a distinction with very low levels in the gout population and very high levels in bacterial infections. In the range, you can see there is overlap. However, serum urate levels were markedly different in the two studies. The conclusions of this was that serum procalcitonin may be clinically useful in distinguishing these two similar clinical presentations. My concerns about this were that these were not septic arthritises that they were comparing it to, but rather bacterial infections in general. And so we would want to see more data specifically about what serum procalcitonin levels might be with bacterial infections of the joint. And then, of course, the problem of whether or not this would be a test that would be available on a stat basis to help distinguish these. Another interesting group of presentations had to do with dual energy computer tomography in gout. We've seen these pictures over and over again in the literature, wonderful pictures of the ability to distinguish bone from tophi with the dual energy approach. And here we see some volume rendered images that were presented in a paper by Dr. Choi a couple years ago. Some science has been attempted to be added to these, and several abstracts relating to DECT scan in gout were presented. The first one was abstract number 209, detection of periarticular urate deposits in DECT in patients with acute gouty arthritis out of Germany. And the interesting thing with this is that these were patients with very early onset disease, and these patients that were experiencing their first very early attacks of gout, that already 11 out of 14 of these patients had clear-cut urate deposits on DECT scanning. Another abstract on the topic of DECT had to do with the diagnosis of gout using DECT as far as its accuracy and diagnostic yield, and this was out of Mayo Clinic. The results of this study showed that compared to the gold standard, which of course was the synovial fluid evaluation for monosodium urate crystals, was conducted in 40 gout patients, and you can see a very high sensitivity and specificity for DECT scan when compared to the gold standard. And the only false positive cases were 3, and they were all 3 in the group of 10 patients that were experiencing their very first attack of gout when the study was done. So this was very early on in the course of their disease. A third abstract on the topic of dual energy computed tomography in gout was abstract number 1618 by Nicola Dalbeth and her associates in New Zealand that assessed tophus size and compared it to the other physical methods of measuring tophus. And this is a very important process, especially with recent therapeutic aids that where reduction of tophi is going to be a marker of effectiveness of these drugs. Their method was to take 25 Gouty patients, and all had at least one sentinel tophus, and up to 3 were measured in this study per patient. You can see compared to the other physical measures, which included the veneer calipers, tape measure, or a tophus count, and looked at the correlation coefficients interclass, with DECT scan, there really was a much better correlation as far as detectability and reproducibility. So the conclusions of this study was that DECT was a highly reliable method for assessing tophus volume and potentially may be used in further studies. There were a couple of interesting abstracts about the comorbid conditions that we see in patients with gout, and this first one out of NYU was abstract number 223 and entitled Gout versus Hyperuricemia as Risk Factors for Coronary Artery Disease, a pilot study. In this, they were looking a prospectively controlled cohort pilot study to assess the relative contributions of asymptomatic hyperuricemia, which we'll abbreviate as HA here, and gout to those that develop coronary artery disease. For the definitions they used, you can see that there were 55 controls that didn't have gout, and their serum uric acid levels were less than 6.8 milligrams per deciliter, and they didn't have any inflammatory arthritis. The asymptomatic hyperuricemic patients, there were 30 of them. Again, no history of gout, but their serum urate levels were elevated and greater than 6.8. And the gout patients, 31 of them were diagnosed by ACR criteria. That when you looked at these patients, clearly the serum uric acids were different by definition. The amount of hypertension was decidedly greater in the gout patients compared to either the asymptomatic hyperuricemia controls, as was the amount of baseline chronic kidney disease. The amount of coronary artery disease, either by self-report or by chart review, which were similar, were also higher in the gout group compared to either the asymptomatic hyperuricemia control. Also, when you broke down the group that had gout, depending on how well their serum uric acids were controlled, if the serum uric acid was less than 7.8 versus those that were equal to or greater than 7.9, there was a distinction here as to the amount of coronary artery disease that existed in these patients, with those with higher uric acid levels having more coronary artery disease. So in the controls, as well as in the asymptomatic hyperuricemic patients, there was no change in the coronary artery disease rate that was seen within those groups based on the spectrum of serum uric acid levels they had. So the conclusions of this study were that gout conveys an additional level of risk for coronary artery disease beyond that of hyperuricemia. Another abstract that had to deal with the comorbid conditions associated with gout was found in abstract number 1032. Uncontrolled serum uric acid levels is associated with an increased risk of developing renal disease in veterans with gout, by Krishnan and associates in a study sponsored by Takeda. In this, they wanted to look at the impact of uncontrolled serum uric acid levels on the risk of developing chronic kidney disease in patients with gout. Their methods were to look at the database for VISN 16 in the VA system, and there they found over 2,100 male patients with gout, but did not have pre-existing renal disease, and then they monitored these patients for an average of 80 months. by their definition, serum uric acid control was if the serum uric acid level was less than 7.0, and if it was uncontrolled, if it was greater than or equal to 7.1. And the results of this show that the renal disease-free rate measured longitudinally changed and was different between those that had controlled serum uric acid levels on the top line versus those with uncontrolled serum uric acid levels on the second line. And you can see that the rate of decline was about 3% per year in the controlled, but was much higher at about 5% per year in the uncontrolled group. And the conclusions from this study was that in patients with gout, uncontrolled serum uric acid levels are associated with an increased risk of new kidney disease. This next section has to do with drugs that have already been approved by the FDA, and then later we'll get to those drugs that are still in the pipeline. But this first abstract was interesting, and it came from Lisa Stamp, and again, her colleagues from New Zealand, number 2579, and it's titled Starting Dose, but not Maximum Maintenance Dose, is a risk factor for allopurinol hypersensitivity syndrome, a proposed nomogram for safe starting doses of allopurinol. And this is a topic that's worried us all for many decades. And what they did is they looked at this rare condition, the allopurinol hypersensitivity syndrome, that's estimated to occur in about 1 to 3 per 1,000 patient starts on allopurinol. It's rare, but it's potentially fatal, and so it'd be nice to be able to predict who's going to develop this. There are some gene markers in specific patient populations, but that's not universally applicable. The methods that they used was a retrospective case-controlled study of 54 cases of this hypersensitivity syndrome to allopurinol, and then they did some controlled matched patients, 157 of them with gout that were started on allopurinol. And their conclusions of this, and there are nice figures that are within the ACR abstract handout book of this, is that a starting dose of allopurinol of 1.5 milligrams per milliliter per minute of creatinine clearance that the patient has is a low enough dose to avoid most all risk for developing the allopurinol hypersensitivity syndrome. So this is the first time a number has really been given to this. They also showed that the progressive uptitration of allopurinol to achieve the target serum uric acid levels, which is the recommendation both of EULAR and in the upcoming ACR guidelines, is not associated with the allopurinol hypersensitivity syndrome. Another interesting abstract about modifying the way that we use medications comes from Herb Barif and the study out of Savient looking at pegloticase, number 2582, characterization and management of infusion reactions in refractory chronic gout treated with pegloticase. And in this study, they retrospectively looked at their phase 3, the randomized controlled trial, as well as the longitudinal extension of the open label extension of the phase 3 trials. And they had 169 patients that had been randomized to pegloticase. That group had 115 infusion reactions in over 3,000 infusions. And this was the interesting part, and that was that the infusion rates per 1,000 infusions was markedly different depending on what the monitoring serum uric acid level was just prior to the infusion. So if the if the serum uric acid level was less than 6.0 in either the randomized controlled trial or the open label extension, the rates of infusion reactions were less than 1%, whereas if the serum uric acid levels just prior to the infusion had jumped up to above 6, then it was about 5%. The conclusion from this was that routine pre-infusion screening of serum uric acid levels, which is an important thing, is important, and if they are elevated, meaning that the pegloticase has lost its efficacy, that discontinuing the pegloticase would greatly reduce the likelihood of these infusion reactions. Finally, as I do each year, I like to point out some of the interesting pipeline drugs that are coming our way in the treatment of gout. The first one of these is lesinurad, which we talked about last year, and this is a novel once-a-day oral urate-1 inhibitor. It's an interesting drug in that it was originally designed as an HIV treatment, but was shown to have this rather remarkable ability to lower uric acid by its uricosuric effect. There was a number of abstracts related to lesinurad. One was by John Sunday, again sponsored by Ardea Pharmaceuticals, number 1021, entitled Efficacy and Safety of Lesinurad, a novel uricosuric agent given in combination with allopurinol in allopurinol refractory patients. A very interesting study that again showed that when allopurinol in usual treatment doses is combined with lesinurad, that there is almost complete ability in patient populations to get them to the targets of less than 6 and many of them to less than 5 milligrams per deciliter. Another study by David Haggerty, again sponsored by Ardea, was number 1030, the pharmacokinetics, efficacy, and safety of lesinurad in individuals with mild to moderate renal impairment, a very important study since our previous whole experience with uricosuric, such as probenecid, showed that these drugs were not terribly effective when you got down to moderate renal impairment. Another important drug that's been talked about in previous ACR meetings also showed up again, and that is BCX 4208. And this is an interesting drug because it inhibits purine nucleoside phosphorylase, or PNP, which is the enzyme just immediately upstream from xanthine oxidase. It's also the enzyme that's deficient genetically in a certain subset of patients with immunodeficiency states. And there are two abstracts related to this that I'd like to highlight. One is abstract number 1018, which said BCX 4208 synergistically lowers serum uric acid levels when combined with allopurinol in patients with gout. And this was a phase 2 dose-ranging trial with Alan Hollister as the presenter. Again, showing, as with lesinurad, that if you combine these with known forms and currently used forms of uric acid lowering therapy, that you can get much greater efficacy than with the monotherapy. Another abstract, number 1026, showed a non-clinical drug-drug interaction study of BCX 4208 in the treatment of chronic gout, and this was essentially looking at the interactions with the P450 enzyme systems, and showed that unlike a lot of the other drugs that are used in combination with allopurinol or to treat chronic hyperuricemia, that the drug-drug interactions were going to be not a major problem with this drug. Also important about this that came out in the presentations was that there was not a significant increased risk of infections, something that we had all worried about given the nature of the enzyme inhibition and the immunodeficiency state that it causes as an inborn error of metabolism. The last pipeline drug that I want to mention is this one by Metabolics, arhalifenate, and this was in an abstract number 2584, which said arhalifenate, a potential novel treatment for hyperuricemia with or without metabolic comorbidities in patients with gout. And this was a meta-analysis of urate-lowering in 4 phase 2 trials with type 2 diabetes. This is an interesting drug because it is a PPAR gamma agonist, the type that's commonly used in the treatment of type 2 diabetes to increase insulin sensitivity. And this drug did those things in their phase 2 trials as far as lowering glucose, of improving triglycerides, but it also had a remarkable effect on lowering serum uric acid levels. And so it has been further developed along the lines of a uricosuric agent again, to be combined with either allopurinol or febuxostat. And just in the past week, there have been reports of successful trials with febuxostat in combination with this agent. Finally, let me give you my thoughts on gout research as far as presentations at the ACR meeting. I thought that there was a wonderful number and quality of gout-related research presentations that show us some new insights about gout and hyperuricemia and how to treat it. Under diagnostic tools, we talked about the potential use of serum procalcitonin to help distinguish gout from infectious arthritis. We also talked about the diagnostic and monitoring capabilities of dual energy computed tomography and looking at urate deposits throughout the body. As far as the comorbid conditions associated with gout, we saw that patients with gout, more than just simple hyperuricemia, were associated with the development of coronary artery disease. Similarly, uncontrolled serum uric acid levels in patients with gout markedly increased the incidence of new kidney disease in patients with gout. As far as improvements in the way we conduct business with our currently approved drugs, Lisa Stamp out of New Zealand gave us a guideline of how we might start allopurinol at rather low doses in order to avoid the allopurinol hypersensitivity syndrome, and she gave us a number of 1.5 milligrams per millimeter per minute of creatinine clearance as a reasonable guideline for starting that drug. Then also the studies from Savient that if we use the pre-infusion serum uric acid level as a mechanism to decide whether to continue with the pegloticase or not, that we are likely to decrease the event of infusion reactions. And finally, there were 3 new drugs that are in the pipeline to help us treat hyperuricemia, and they all function as uric assurics and will probably be combined with existing forms of urate-lowering therapy. I appreciate your attention. Goodbye.